Hello everyone, I am Michele Bustard, a family nurse practitioner certified in nephrology, and my project was a clinical practice guideline for reducing the progression of CKD through sodium monitoring. I would like to thank my DMP chair, Dr. Holly Jastek, for all of her help with this project, and to Dr. Wunderlich for being my second reader, and to Dr. Trina Banerjee for allowing me to pursue my project at the nephrology office. The project aim was to develop a clinical practice guideline to assist the nephrology providers in a 24-hour urine collection for new patients with stages 2 to 4 chronic kidney disease. By doing the 24-hour urine for sodium, this will help prolong the renal function with education and sodium tracking. Background and significance. Chronic kidney disease is a significant public health concern that affects at least 697 million individuals worldwide. Increased consumption of sodium is a recognized reversible determinant of chronic kidney disease progression. High sodium levels are found to have a clear correlation with increased risks of renal decline since it antagonizes hypertension and proteinuria. Dietary sodium intake is a modifiable chronic kidney disease risk factor responsible for 9.5% of chronic kidney disease-related disability adjusted life years. By sodium reduction, blood pressure is lowered and consequently slows the development of proteinuria and albuminuria. Continuing with background and significance, the evidence supports the use of low-sodium diets as a cornerstone of chronic kidney disease care to reduce the progression of the disease and the burden of the complications. The results reveal that high sodium levels hurt renal function and that excessive sodium consumption constitutes a real threat to health. By reducing sodium in the diet, studies have shown that glomerular filtration rate is improved. Literature review. In clinical practice, a 24-hour urine collection kit to monitor sodium intake provides a more accurate picture of an individual's sodium consumption. Chronic kidney disease affects millions of people and is now a health issue that needs appropriate treatment. Excessive dietary sodium worsens the ailment by making the kidneys dysfunctional and elevating the blood pressure. Many CKD patients continue to have high sodium levels mainly because of their diets, lack of proper education, and not being closely monitored. There was a 5-year longitudinal study conducted from Korea which recommended to permanently adopt a low sodium diet by reducing their salt consumption, and this study did result in reduction in proteinuria. Continuing with literature review, improving GFR, which is the glomerular filtration rate, with a low sodium diet. With low sodium in the diet, less pressure in the kidneys result, which then prolongs the renal function. One clear point that helped improve chronic kidney disease is a low sodium diet. And sodium intervention led to an average reduction in sodium excretion rate of 30.3 millimoles in 24 hours compared to 2.9 increase in the control group from Amsterdam. Continuing with literature review about albuminuria decreased with low sodium diet. An increase in sodium in the diet directly affects urine albumin excretion, and cutting dietary sodium can result in reduced albuminuria and proteinuria. Findings in a Korean study demonstrated that clients with high albuminuria experienced reduction in their GFR, with a mean group of 53.3 milliliters. A decrease in the GFR was directly correlated with the shift in the albuminuria severity across all patients' categories regardless of age, gender, and other predisposing factors. And by decreasing the sodium intake by 36% was also effective in reducing albuminuria in 6 studies. Literature review about blood pressure improvement with low sodium diet showed a decrease in salt intake brings down the blood pressure significantly, which protects against worsening kidney disease. And a study in 2023 found that when they recommended that the intervention group reduce their salt intake, their collective systolic and diastolic blood pressures decreased by 7 and 2.5 millimeters of mercury in a as shown by their 24-hour urinary sodium excretion records. There's also a corresponding decrease in the systolic and diastolic blood pressure intervention group than within the control group, demonstrating that salt reduction plan yielded better results as well. Theoretical framework. The theoretical framework model I chose for my DMP project was the Haynes-Jones model, which emphasizes the value of clinical practice guidelines in implementing evidence-based practice, giving the patient dietary information on ways to reduce their sodium intake, and showing them the result of their 24-hour urine, tells them how much sodium they are consuming, is an example of a patient-centered approach that I used in this project. The Haynes-Jones model states that patients should expect a clear explanation about the effectiveness of treatments as they are offered, again showing exactly to the patient how much salt they eat in a 24-hour period from the 24-hour urine collection is key. Method and designs. The scholarly project was conducted in a specialized nephrology practice in Mullica Hill, New Jersey, that employs 1 nephrologist, 3 nurse practitioners, and 1 physician assistant. The practice averages about 4,000 patients a year and is made up of a diverse team of CKD patients at different stages of CKD progression. A systemic approach was used in the scholarly project so that the clinical practice guideline could be elaborated using extended evidence synthesis methodology. In this clinical practice guideline for this project, the appraisal of guidelines for research and evaluation, 2 instrument was used, commonly known as the Agree-To tool, which allows evaluating the quality and applicability of clinical practice guideline based on 6 different domains. The Agree-To tool allowed conducting quantitative evaluation in form of the Likert scale rating among 7 points, and qualitative one based on the commentary of the stakeholders. Continuing with method and design, criteria were that the participant should be 18 years old or older, be a medical doctor, a physician's assistant, or a nurse practitioner, and must be currently practicing in nephrology and be obligated to attend patients directly. Experience treating patients with chronic kidney disease all stages. The guideline included giving each new patient with chronic kidney disease stage 2 to 4 a canister for a 24-hour urine collection, a specimen cup for the spot urine for albumin to creatinine ratio, and a follow-up appointment in 2 weeks. The data will then be used to treat the patients according to how much sodium is in their diet and how much protein is being spilled. The project occurred according to the planned 8-week schedule. Continuing with the method and design, each week for 8 weeks, a domain of the Agreed-To tool was presented to the stakeholders and then scored. On week 7, 2 extra items to assess the overall quality of the guideline was given, and then scored. Week 8, all the domains scored were entered into an Excel spreadsheet and presented to the stakeholder, and then determined if the clinical practice guideline was acceptable for use in the office. The sample. All inclusion criteria were created to guarantee that the evaluators had sufficient clinical expertise and an understanding of chronic kidney disease management to receive a comprehensive feedback on the proposed guideline. The inclusion criteria were that the participant be 18 or older, be a medical doctor, a physician's assistant, or a nurse practitioner, and must be currently practicing nephrology. The data was collected by the Agree-To tool, which is a freely available instrument, which did not require any special authorization for this project. 4 healthcare professionals were used as stakeholders as the appraisers for the Agree-To tool. 50% came from 2 nurse practitioners, 25% was 1 physician assistant, and 25% by the nephrologist. The Agree-To tool has 23 structured items under 6 domains. In every one of the 23 items, there's an area where reviewers can comment regarding their ratings. There is a 7-point scale of the Agree-To instrument in which reviewers can score 1 point for strongly disagree and to 7 strongly agree. There's 2 extra items to assess the overall quality of the guideline. The last step is the appraiser's recommendation for use of the guideline. This is listed with an answer of yes, yes with modifications, or no. Data analysis. Quantitative and qualitative using the agreed-to instrument. The quantitative approach involved the numerical rating of 7-point scale of the 23 items in 6 domains. There's a certain formula that can be applied to each domain score as a percentage. You take the obtained score minus the minimum score, divided by the maximum score minus the minimum possible score, multiply that by 100 and get your percentage. The data collected and filled in by the 4 reviewers that completed the instrument was described and summarized. The qualitative part was meant to study the reactions and comments of the reviewers, especially how they managed to answer the final recommendation questions regarding their wish to using the guideline per the agreed-to tool. These comments on the agreed-to tool could be answered with yes, yes with modifications, or no. The results. This is a pie chart of the 4 stakeholders, being that 50% were 2 nurse practitioners, 25% 1 physician assistant, and the last 25% was the nephrologist that rated the clinical practice guideline using the agreed-to tool. This pie chart shows the number of items in each domain of the agreed-to tool, which was scored by all 4 stakeholders. Domain 1 had 3 items, Domain 2 had 3 items, Domain 3 had 8 items, Domain 4, 3 items, Domain 5, 4 items, and Domain 6 had 2 items. Continuing with results, the agreed-to instrument stated that the appraiser strongly disagreed with a score of 1 and strongly agreed with a score of 7. There were 23 items in all that needed to be scored throughout the 6 domains. To compute the overall domain total representing the scores of 4 appraisers, all the scores were added together. This chart shows the domain quality scores, and it's a comparison of the total points possible to the total points awarded for each domain. The domain scores range from 98 to 100% from lowest to highest. 100% was attained in Domain 1, which was scope and practice, 100% in Domain 2, stakeholder participation, 100% was received in Domain 3, rigor of development. In Domain 4, 100% was scored, which was for presentation and clarity. 98%, which was the lowest score, was in Domain 5, applicability, and 100% was received in Domain 6, which was editorial independent. The aggregate scores for all domains was 99.6, above the 70% criteria, which was suggesting that the guideline was remarkably strong. High quality criteria refers to a score in a domain that are higher than 70% according to the agreed-to tool, which allows participants to establish an acceptable level spanning all 6 domains by taking into account all domain scores. The lowest domain score was 98%. The author chose to use a greater than 70% threshold in this project. If the threshold score was lower than 70%, it would indicate an area of weakness and the clinical practice guideline would have to be adjusted. The last step was if the appraiser recommended using the guideline. This was listed as yes, yes with modifications, or no, and this was not part of the 23 items in the 6 domains. Piggybacking off the last slide, with the last part was the guideline recommended for use by the stakeholders, and they can provide feedback with the overall quality of the guideline. The guideline quality received the maximum score of 7 out of 7 from all 4 appraisers. The results show that this is an agreement on how good, clear, and practical the clinical practice guideline is. Limitations. A few stakeholders observed that these evaluation tasks at times conflicted with their traditional clinical roles, and that the scheduling or workload planning was crucial in the implementation projects of the guidelines. The nephrologist schedule was hectic, and time was spent on different days than when I met with the other stakeholders to complete the agreed-to tool. However, the data was collected on time and thoroughly completed by all stakeholders. Discussion. The evaluation of the clinical practice guideline based on the agreed-to tool revealed a high-quality score in all 6 domains, with the highest scores between 98 and 100%. The guideline was rated at the maximum possible quality by all stakeholders, hence, they advised using it without any changes. Sodium intake influences chronic kidney disease progression by raising blood pressure, cardiovascular, and renal complications that ensue. In this case, sodium reduction reduces blood pressure and consequently slows the development of proteinuria and albuminuria. The guideline provided a standard order for a 24-hour urine collection for sodium, a dietitian referral on the first visit with a new patient with CKD. A container is now given for the 24-hour urine collection with the directions, the referral is placed for the dietitian, and a follow-up appointment is made at the end of that visit for a 1-month appointment. Implications for practice. Historically, practice guidelines regarding sodium reduction have not been easy to follow by patients without conclusive tracking modalities. Nevertheless, it is clear that the literature shows that a low intake of sodium leads to a substantial reduction in blood pressure and proteinuria, which are crucial in stopping the development of chronic kidney disease. The guidelines should be used to standardize the 24-hour urine collection to assess sodium, albumin to creatinine ratio, and a timely referral to a dietitian and proactive patient-centered disease management. Continuing with implications for practice, one key strategy that can significantly help to decrease the financial cost of CKD and subsequent development of end-stage renal disease is the reduction of sodium. Statistics show that the average total expenditure of all-cause CKD stages 4 and 5 cost is about $76,669 in commercial insurance programs and about $46,000 in Medicare. Universal clinical protocols that include sodium reduction strategies should be added to the healthcare policy, which would include cost-effective chronic kidney disease management. Continue with implications for practice. The focus on early intervention means of dietary counseling and patient-led tracking helps practices control disease progression. By having the patient place a sodium tracker on their phone would allow obtaining real-time objective feedback and actively involve the patient, which reduces the chances of CKD progression. Conclusion. Chronic kidney disease is a global epidemic that has an approximate prevalence of 8 to 16% of the total population. Dietary sodium is the most modifiable risk factor. Large amounts of sodium intake accelerates renal failure by intensifying the presence of hypertension and proteinuria. The average American diet consists of 5,300 milligrams of salt in one day. The majority of patients fail to follow the low salt guidelines due to lack of counseling and effective monitoring instruments. This DMP project was able to develop an evidence-based clinical practice guideline that would address this gap in patients with chronic kidney disease stages 2 to 4 by combining a 24-hour urine sodium analysis, targeted dietary consultation, and a mobile health track implementation. The proposed project offered a long-term, scalable model that will actively empower the patients. This patient-centered guideline will not only reduce the colossal economic cost in our healthcare system caused by end-stage renal disease, but will also add to the improvements in the longevity and the quality of life of millions of people with chronic kidney disease. The DMP Essentials helped me achieve this goal. Each class in the program focused on 1 or 2 of the essentials at a time. By doing the research and creating a clinical practice guideline that I see implemented every day in the practice in the nephrology office brings joy knowing I have created something that has a huge impact on all patients with chronic kidney disease to prolong their renal function, which would decrease the need for dialysis. Also, being in the program, I learned exactly how to research and pinpoint the things that need to be changed and how exactly to change everything. And for me personally, I've completed everything there is to do in nursing. I started as an LPN back in 1995, so this is a good accomplishment for me. Thank you very much. I hope you enjoyed my presentation. The following 3 slides are all the references used in the scholarly project.